Right. Hello, everyone, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I would like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions buttons next to the Raise a Hand option in the Zoom menu. The public slide deck will be made available under the Education tab. I will post the link in the chat along with a short questionnaire for asking for seminar and topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, our next impact seminar will take place on Tuesday, August 1st with Dr. Taj Mustafa, Assistant Dean of DEI for the Medical School at the University of Minnesota and the Chief Equity Strategy Officer at mHealth Fairview. There will be no seminar in July. CLHSS will be hosting its first conference on September 18th and 19th, and I will put the conference link in the chat. And with that, I will turn it over to Dr. Tim Beebe to introduce our speaker.
Thanks, Stephanie. I'm very pleased and excited to introduce Dr. Stacie Vilendrer of Stanford University to today's impact session. She is a family physician and medical director of the Evaluation Sciences Unit within the Division of Primary Care and Population Health at the Stanford School of Medicine. She completed her MD and MBA at Stanford, her residency in family medicine at UCSF, affiliate Santa Rosa Family Medicine, and the Stanford Intermountain Fellowship in Population Health and Delivery Science. Dr. Vilendrer uses mixed methodologies and implementation science to study quality improvement initiatives in diverse clinical settings, clinical incentive and feedback design, and how to effectively incorporate emergency technologies into clinical practice. Most recently, she has led evaluations around Stanford's COVID-19 response in telemedicine, primary care, and community outreach. Her talk is entitled Engaging Clinicians in Quality and Value, Improvement in Learning Health Systems on the Stanford Experience. So with that, please join me in welcoming Dr. Stacie Vilendrer to the Zoom call.
Thank you so much for having me. This is just a special privilege for me to be here because I was born and raised in Eden Prairie, Minnesota, and my family is still there. And Grand Rapids, Minnesota is my happy place. My parents have a lake home up there, so I spend as much time as I can in the summers up there.
Oh, that's where I'm from. That's where I grew
really?
up.
Oh, next I was gonna put
that's really kind of creepy and weird. Fun. All right, that's a beautiful place up there.
Yeah, I was gonna put this, like, I was in bed last night and I was like, I need to put Judy Garland shoes up there and talk about Grand Rapids, and then I didn't get the Judy Garland shoes in, the red shoes, but there you have it. I said it. All right, so I am excited today. So this is kind of my background. Kind of unusual. I did my business degree and family medicine, and then I did this research fellowship. So kind of, I live at the intersection of medicine, business, and research, and kind of producing research on sort of the operations of medicine. So that's kind of a fun niche that I have found. I am medical director of the Evaluation Sciences Unit, which is a research group at Stanford, which I'll talk about in a moment. I have organized my research interests into the quintuple aim, which we've all seen: quality and safety, cost, patient experience, clinician experience, and equity. And these are just some of the areas of research that I'm interested in, and we'll use this as our agenda. I'm going to talk about two programs that we have studied at Stanford to engage clinicians, mostly physicians, but clinicians more broadly as well. We do a lot of work with nurses and other folks and medical assistants. And so the first engagement program is quality and safety. The second is on values. So I have a clock in front of me. I really want to save a good chunk of time for discussions. So hopefully I won't have to rush to do that, but we'll be able to kind of get through the ideas around these different programs give you a sense of them, and then, talk about, whatever you guys want to talk about, what works, what doesn't work. Fortunately, these are at the point where they've been written up, they've published, they're out there, and we're actually in the process, to kind of say the end first, we're in the process of trying to combine these into like a global physician incentive program at Stanford, and that's still in the works. So there's not too much I can say about that. But up until this point, for the last 4 years, these programs have been separate. So the first program, engaging clinicians in quality and safety. So we have, since, well, let me just go to, let's start with the background. Okay, so we all touch learning health systems, we work in learning health systems. This is, after reading several definitions, this is kind of the definition that I came up with, based on, several that were out there. We aim to embed knowledge generating scientific, informatics, incentive, and cultural tools into daily clinical practice to improve care. Clinicians are often, especially when they're on the front line, they can identify the problems, they can deploy initiatives, they can anticipate the impact, especially on patient care, and then they can adjust the interventions. So, the admin and sometimes the research folks sitting up in the ivory tower, kind of thinking about how things are going to work, really need to be working in close partnership, hand in hand with the frontline clinicians on anything that gets implemented, as this group surely knows. And so are clinicians prepared to do that? I would say yes, to some degree. I think the emphasis in the past several years has been on increasing the quality improvement training. So usually there's a requirement for ACGME for physicians to come out with that training, but their skills around evaluation of those quality improvement methods, or there's often not programs for that. So it's a major gap. It's also a major gap later on in clinicians' careers when especially if they work in the academic setting, when they're looking to publish, to get those promotions, they often don't have the skills to do that. So that's a sort of a pet passion of mine, is helping clinicians build those skills, which I'll talk about at the end. When you do quality improvement projects and they lack methodological rigor, it can generate spurious conclusions, which lead to potentially harmful or wasteful changes within a health system. So we really like to bring in some rigor. Stanford is not unlike most academic institutions, in that the School of Medicine is separate from the health system. So the faculty are employed by the School of Medicine and ultimately answer to the dean. The Stanford Healthcare runs the health system, collects the patient money, and then there is a financial transfer from the health system to the faculty, to the School of Medicine for the faculty. And there's a lot of negotiation and conversations around what that's going to look like, and especially what the incentives are around the financial aspect of it. So if the health system wants physicians to focus on, upping or reducing readmissions, improving length of stay, they might put some incentives in there. If they want them to just focus on quality improvement in general, which is how it's been, there's an incentive there. So that's how this program, the Improvement Capability Development Program, is what we call it, ICDP for short. So that's that acronym. So when you see ICDP, just think, okay, physician incentive program, there's some money at risk. So that money flow from the health system to the departments, to the School of Medicine, and then each department, and then it gets divvied out. And the ask from the health system is that each department has 2 to 5 leadership approved projects. So they apply to then the health system with saying, this is what we're going to do for our quality improvement project. And, here's our stakeholders, here's the work we've done so far. The health system leadership says yes or no. And usually they say yes. And so then that is approved as an official quality improvement project in this ICDP program. We also have designated physician improvement leaders with the unfortunate acronym PIL, although we try not to call them that. So there's at least one for each department. Sometimes there's an associate one if funding allows, and they have a chunk of their time, usually not more than 25%, carved out to help lead lead these projects so that their department can see success in quality improvement and make sure that they secure that at-risk funding, so that like incentive funding that takes place. So that's the incentive program, and this is focused purely on quality improvement, quality and safety improvement. And if there's a value benefit, great, but it's not the focus. So where do we come in? So this is my research group. These guys are awesome. They're PhD level, doctorate level physicians. We have qualitative scientists, quantitative scientists. We have several, master's level folks, and we were started by Steve Ash, who's faculty, and Marcy Winget, who's our executive director. So the top two in the middle there in 2017 as an embedded research group in the health system. So we do about half to 2/3 of our projects within the health system, and that could include the adult side, the pediatric side, and we have some community hospitals as well, and community clinics we work with, and then the remainder of the funding could be outside projects. So we might work with either an outside health system or a foundation to do kind of a different sort of research project. But one of those interesting ones, we're working with a group out of New York that's building a social determinants of health or social drivers of health network. So that's kind of fun. That's funded through the Robert Wood Johnson Foundation. So it's a mix of internal research projects within the health system and then some outside ones. Our mission is to inform the delivery of high quality coordinated patient and family centered care through embedded healthcare delivery research. Just a word on implementation science. I think this group is very sophisticated. Just looking at your website and having talked to some of you, but just as a reminder, I think of implementation science as kind of the far right end of the spectrum of science. If bench research is on the left side, clinical research, implementation science is putting what we know works into practice and making sure it works in different settings, and asking questions around why it does work, why it doesn't work. And so another way I like to think of it is, let's say you have a cool idea in medicine, you can answer that question of, did that idea work? Why or why not? So we always want to measure the impact of what we do, because there's time and resources in any initiative, and implementation science kind of gives us the language and the frameworks, language, skills, methods to do that. So, all right, so I explained ICDP, that Physician Incentive Program. I explained the Evaluation Sciences Unit, which is this embedded research group that I'm medical director of. And so in 2019, 4 years ago, we did a collaboration. We launched this collaboration where we said, you know what, these physicians are leading these quality improvement projects. Why don't we come in and help them elevate it, elevate the rigor of the evaluation part of it, see if we can't hit this double bottom line of both informing operational decisions and disseminating those learnings through scholarly work. So outside groups such as yourselves, learning health systems might be interested in that. So we use mixed methods for that as applicable, and it's very bespoke based on the project. So I like to think of each project as unique, but they're all supercharged because these evaluators, like a team of evaluators / researchers, join this quality improvement group, quality improvement project, and then together each project has a collaboration, and we come out with more rigorous results than we otherwise would have, more like experience and careful thought around how the project is shaped to answer operational questions, and then of course publications. Another way to think about it is, and this came about in this image came about in our second year, where we kind of got in there, learned what was working, what wasn't working, figured out roles and responsibilities. And so then we came up with this just Venn diagram. So on the left, you have the local, quality improvement team. They focus on local problem solving. They'll use things like everything we learn about in terms of like lean methodology, quality improvement methods, so A3s, PDSA cycles. They'll come up with some sort of intervention design. And usually on the back end, so if the two big circles are pre-intervention and post-intervention, with the intervention somewhere in the middle, usually the QI team will come out with like a run chart. Oftentimes there's not a comparison group, and they don't have, you know, the statistical skills to come up with p-values and so forth. So then on the right side is what the evaluation sciences unit or an embedded research team can bring, which is adding this piece around creating generalizable knowledge. So in the pre-intervention phase, we can help identify comparison groups, like feasibility, operationally viable interventions, work on data collection, analysis, and then develop the academic projects. So it really is a combination, like both groups have something to bring at every stage. And it is great to really work together and bring different skills to the table. So the way that we set this up is a two-part phase. One is every department is invited for a consultation. And then the second part is a subset of projects. And let me first say, the consultation, we learn, the researchers learn more about the 2 to 5 projects that folks are doing, where they are in that process, what they're thinking in terms of intervention, design, methodology. And then we're sort of we're providing support to each of those projects, offering suggestions, sometimes just connecting them with other people in the health system that are working on similar things. Maybe we know about something going on the pediatric side, and the adult side, and the pediatric side has it figured out, the adult side doesn't. And so we kind of bring those groups together. That's a lot of what we play, a lot of what we do. And then we'll take careful notes on that. And then we bring it to a committee of senior leadership who then helps us pick a subset of these projects for a deep dive evaluation to actually partner with full time. So in terms of a timeline, our fiscal year starts September 1st. And so we start the consultations and finish them up in the fall. Sometimes we'll take 2 or 3 meetings. Sometimes we'll take no meetings with the department if they don't get back to us. That's usually less than 20%. But especially in the early years, we're realizing that the more success we have, the more departments are interested in working with us. So that's good. And then around the beginning of winter, we'll present those notes. The leadership committee, that's made of operational quality and research leaders, and they'll select the project. The kind of 3 things we look at is operational priorities. I would say that's probably number 1. The rigor of the study design. So can we get something interesting and out of this? Can we even get the data? Is there a comparison group? Things like that. And then potential for broader impact. And then the rest of the year, once those projects are selected, we'll take a subset of our evaluation sciences team. Usually it's a clinical person, such as myself, a quantitative and a qualitative person, and then sort of like a project manager role. So those 4 roles, and we'll sign at least one of those, we'll sign each of those 4 roles to a project. So each of us will be on like 2 projects out of 3 that are ongoing. And then we wrap it up in the spring and write the manuscripts over the summer. It's the idea. Clinicians, we ask them to think about their project carefully before they meet with us. How does it fit within the health system's priorities? What's been published to date, problems and goals, and so forth. And so then what we bring to the table, just a different way to say this, identifying comparison groups, identifying feasible and operationally relevant outcomes. So people come at this with huge project scopes, so we help them narrow it down. They might not have access to the electronic health record, and so actually we have the ability to pull that data directly with our in-house analyst, and that analyst, to get that ability, he is able to work in Clarity, which is Epic's sort of data pool, and that took 3 courses in Wisconsin with Epic to be able to have that ability. But now, fortunately, we have that ability. And then, collecting, interpreting, analyzing data, bringing the mixed methods analysis where appropriate, and then helping to produce these academic products. These are the departments we've worked with for the last 4 years. We try to spread the love, so to speak, and kind of pick different departments each year, with the exception of medicine, because it's just our massive. So we have worked with hospitalists in medicine, cardiology. We're just starting or midway through a project in palliative care. And so, we kind of pay attention to being able to spread these resources out. We have to date done 13 projects. So we had the 12, one project was split into 2. There was one paper that never actually got out the door for a project because of poor EHR data. It was just much noisier and more difficult than anybody had anticipated. But other than that, every project has at least 1 to sometimes 5 papers that are connected to it, and then a host of conference abstracts and sometimes oral presentations. And what's really important to us, because I guess I didn't talk about funding, because we're funded in part through the health system itself, and so it's a little bit of the health system wanting to prioritize, high quality improvement projects, and then also the School of Medicine is interested in the professional development aspect for their clinicians. So for our clinician partners, when we're putting out these papers, for the vast majority of them, they're serving as either the lead or senior author. So of our 18 manuscripts that have been published to date, 17 of them have served, the clinician partners have served as either co-lead, lead, or a senior author. And most of the time we do this shared first authorship. So a really common thing is a clinician will be leading the project in terms of the operational aspects, be very interested in the research part of it, and it'll be kind of maybe a more qualitative manuscript, but they've never written a qualitative paper. They've never done that. And so a lot of times we'll bring in somebody from our team to do a co-first authorship. And so that's worked out really nice because they have that hands-on education where they're learning how to write those kind of manuscripts. They also get to lead it and go through that process. But then the ESU, the research member, also has that credibility to add to their resume. So just a small example, I've referenced a paper in here that has been written about this, but I think this is a good example of a project we did a couple years ago. This is a good example of a dissemination project. So in our radiology department, they developed this coaching model for technologists, so the people who line patients up, like set it up, work with the computer to get high quality image. A radiologist is reading an image is only as good as the image that's produced. And if you can believe it or not, there's not standardized like atlases for creating those. And so the lead of this project, David Larson, who's a physician radiologist, kind of jokes that he's like, here's the manual for how you evaluate eggs in the United States. There's like, it's like 100+ page manual for like the, food kind of stuff. Is like, how do you get image, how do you like evaluate an egg, the image, the size, and we don't have the equivalent for radiology. So how are we expected to get these high quality images to make accurate diagnoses? And so they had this coaching program in 2 of the modalities, ultrasound and mammography. It was extremely successful. They spread it to several more. And so we went in and we observed that process. We had somebody, a qualitative researcher, observe those meetings. We then conducted a number of interviews, and we really tracked and documented the success and variability of success across the new modalities, X-ray, nuclear medicine, and so forth. And so that was, and then we wrote it up. So that was kind of a fun thing that I think has real downstream positive consequences for patients in terms of getting technologists to level up their skills in terms of capturing high quality images. And the folks involved just really appreciated the whole thing. We've had a number of publications, and we always try to have our work touch on different elements of the health system's operational plan. So they kind of organize it into 4 areas, and these little arrows over to the left are really just saying, what each of our projects are touching on a lot of these at once, which I think is great. Learnings to date, timely access to quantitative data is critical. It was great to have that statistician get access to Clarity and Epic. We need engaged frontline clinicians. Once in a blue moon, we'll have someone less engaged, and it's just harder to complete that project. Define roles and responsibilities early and often. Evaluation meetings, they need to happen separate from the operational meetings. And so we are actually asking clinicians to spend a little bit more time in meetings, but generally we hear positive things that they are getting a lot out of it. So that little bit of extra time is worth it for them. And quantifying the operational impact is always a challenge. We are feeding back information to this health system, but there's not like a good systemic way to track that. We're actually shifting it as of this year. We're going to shift more from local department-based projects to high-level system needs. So Stanford is working on access, readmissions, among other things. And so instead of diving deep with the department on a single project that they picked, we are working with the lead, like our chief quality officer and our chief patient experience officer to come up with projects that kind of hit those higher level needs. And those will, a subset of them will probably be multi-year rather than that 1-year timeline I showed you. Okay. So it's about the half-hour mark. I am going to, because I want time for discussion. So everybody just take a breath, mostly for me. I'm going to take a breath. And I would love to talk to you about engaging our program to engage clinicians in value. So I'm going to hit the highlights, and we can talk about it more after. So there's a program at Stanford called the Cost Savings Reinvestment Program. So we've probably seen the value equation with quality and service at the top, cost in the denominator. And so that's what we're thinking about. With value, you're balancing that quality, safety, service with trying to reduce costs. So this is a trickier area. Similarly, engaging physicians and value is going to be key. They control a great deal of the healthcare expenses. There's that saying that the pen is the most expensive medical equipment. because it's the physician writing prescriptions and making plans for surgery and so forth. They have, firsthand knowledge of clinical workflows. Hopefully they prioritize patient needs. They can lead frontline change. And so I want to talk about the options. So if you're a health system, how do you engage physicians in value? So can everything be boiled down to a 2x2? Maybe, maybe not. But this is a 2x2 that it was helpful for me to think about. So across the top, you have your goal as a health system. Do you want physicians to improve quality, service safety, that kind of thing, versus reducing costs? And then your incentives, so down the left column, can you give them direct financial compensation? Yes or no? What are your options for that? So we'll talk through this. So in the first left upper box where that check mark is, if you want to increase quality, yes, you can incentivize with direct payments that activity for physicians. That is the program that I just described, the ICDP program. And all kinds of health systems have programs like that. You can also offer indirect, or sorry, something that's not direct financial compensation. So, a lot of times health systems are just, that physicians don't get incentives. It's just an expected part of their job. So that would be that. And then, however, if you're trying to reduce cost and give a direct financial compensation, there are very strict fraud and abuse laws. They call them anti-gain sharing laws that limit direct financial incentives. There are programs that you have to apply for through the federal system, the federal powers that be, to get exceptions to those. But you can't say, Stacie, as a doctor, Dr. Vilendrer, if you save $100, we're going to give you $20 of those back. That is not legal except for very rare paths. And so this gain sharing piece was popular in the 80s and maybe early 90s, and then they put this law in place. But it is unsurprisingly effective. So you kind of think, oh, maybe it's nice because incentives direct focus attention towards something. So is there a way we can get the benefit without the very obvious kind of moral hazard that comes with that, of course, which is why the law was put in place. So in the bottom right box, this is now what we're talking about, which is called, so this is the cost savings reinvestment program at Stanford. And then because it was also at Utah, I had to come up with a more global name for it. So we're calling it physician directed reinvestment. And so this then allows, it's an explicit agreement in which the healthcare system reinvests a portion of savings attributed to physician-led cost reduction initiatives back into the area of the physician's choosing, such as whatever they want within like a limited scope. So capital investment, research, education, more quality improvement initiatives. And so you're basically saying, here's an explicit agreement. You guys go run this project, see how much you save. We'll give you a portion of that back, and you can use it for, more CME education. You can use it to, invest in that thing that you needed for your department. You can use it as research funding and so forth. So to put this in different terms, in the typical state, so the two columns, who determines the project choice and who determines how the savings are spent? Typically, health systems determine what the priorities are in terms of saving money. They come up with the ideas. The health system directs 100% of the savings. The physician has variable roles executing that. In gain sharing programs, which I said are illegal, health system with variable physician input determines project choice. Physicians are paid up to 50% of the savings. Health system directs at least 50% of the savings. So that's kind of most of the literature on gain sharing. That's kind of the number that they picked. But remember, that's only legal in very limited settings that have to be pre-approved now. And then physician directed reinvestment. The physicians are coming up with the ideas of the projects. They're saying, hey, you know what? We are missing obvious things on the neurology inpatient ward, which was one of the projects. Let's do a checklist that has a special focus on cost savings. They implement that checklist. That savings from that then gets validated. There's a lot of conversation around how to validate that with the administrative, like financial department. And then there's a shared discussion around who directs the savings. The department chair and the physician project lead can work together to come up with that. So it really is a different incentive structure that's out there that I would say is being underutilized. And I stumbled upon it, and I, thought it was very cool. I asked our lead, the person who really brought this to Stanford is Paul Maggio, who's a surgeon who's our chief quality officer now. And so he said, great, you can study it. And so that's been awesome to have him on board as a co-author, senior author for that. So just comparing the University of Utah, since they had it, with Stanford Healthcare, there's just a little bit of differences between the way these two programs executed this. So you can read more about that in that paper or talk to me if you're curious. Just as background, our Stanford Healthcare's CEO and chief operating officer came from University of Utah, sort of as a pair. And so they were familiar with this. Paul Maggio was on board, and we were able to implement this at Stanford Healthcare. So we wrote that first paper, just kind of understanding the two programs, describing this unique incentive structure. It seemed, so I have the golden holy grail there. That's the holy grail. So it's collaboration across departments. People are telling us, encouragement by peers rather than administrators to change behavior. So if a physician identifies a cost saving project, they're then telling their colleagues. It's not the administrator saying, hey, you have to do this different thing. There's a path for compelling ideas to reach senior administration, and it demonstrated savings without compromising quality. So our little monkey is there because it seems promising, but we wanted to know more. So we did a formal evaluation of this to understand the return on investment based on internally audited numbers. So Stanford has we have cost accounting, and so we that's how they're able to say, okay, how much was saved from this. And so that's all laid out before the project is implemented, and that's how they can give that percentage to physicians. And we just ask these very standard implementation science questions. Adherence to protocol, are you actually balancing it with those balancing the downward cost pressure with the safety, the need to maintain physician safety and quality of care, facilitators and barriers to program success. And then how is this working on physicians? Like, what does it do for them in terms of motivational behavior? So we estimated the cost of the program based on publicly available salaries and who was involved. It's a number of people spent time just on the administration of this program, and then the physician time. So if your project is selected, you don't get compensated time to complete that project. That is kind of on your own time or fit into the admin time you already have. So we found an 11-fold return on investment, excluding any benefit from reinvested funds, which actually would go back into the department, but that was too challenging to measure for all these projects, and then excluding uncompensated physician time. So pretty good. And projects that risked a reduction to quality of care, there was a 2-tier committee selection process. And so if there's any question around the downward cost pressure compromising quality of care, those projects would either be the physician presenting them would say, okay, go back to the drawing board, you need to fix this aspect, or we're throwing it out. And it was we weren't able to find balancing safety measures for every single project, but enough people told us you know, no, I feel really good about this as a clinician. The projects with any question are getting thrown out or reevaluated, or, you know, patients are being protected in some way. So that was nice to hear. Facilitates, as far as facilitators, it facilitates interdepartmental and inter-hierarchical value work. So these silos are being broken down. The latent ideas from the front lines are being surfaced to administrators. Administrative resources are being directed to these projects since they're part of this cohort of high priority value improvement projects. And then the committee ensures like safety and then alignment with the organizational goals. When I evaluated it, it's now been a couple of years, there was just less awareness of the program. I think that's still true today. It's just we have, you know, thousands of physicians at Stanford, and just a few have participated in this program. So how can we get more people to participate in it? There is sort of this unintended adverse consequences. So a couple people said, well, if you really want the funds that come with it, you should wait to execute that improvement until you're officially in the program, because that's when the timer starts, and then they count the savings after that. So there are these sort of perverse incentives around the margins. A dean made a comment. Well, sorry, not it wasn't a dean. It was just somebody. I didn't interview any deans, so I'm not giving away confidentiality. But someone in a leadership position said that they were worried that this could incentivize people just to do the job they were supposed to do anyway. So that was a question. And requirement for staff and operational engagement. So, you know, this is time and resources, so it certainly costs money. Closing in on the end here. So how did it impact physicians in terms of their motivational theory? I love this paper because they took all these different motivational theories and they lined them up. So you've probably heard of Maslow's hierarchy of needs. You might have heard of Pink's Drive. Was a more recent book that came out. And so I liked this intrinsic, extrinsic motivators, and they kind of summarize it into mastery, autonomy and power, relatedness, versus extrinsic as this, you know, financial motivators. And so we found evidence of all of those in physician quotations. So, you know, autonomy, this is a better place because of what I did, feeling like a purpose. The ideological part of me is interested in that. Relationships, it's fun to work in teams. We get to see the data, we get to see how we're doing. We met our goal. People are coming together around this. And then the extrinsic, so if intrinsic is what's inside of you, extrinsic is the external funding, recognition, kind of those more superficial carrots. People talked about the funds. They're saying it's just its existence becomes a powerful incentive. People also talked about the fact that the funding could justify time spent on that. So whereas professionally they were normally incentivized towards producing papers or seeing patients, this allowed them to work on value improvement, and it felt like it was more that their time doing that was justified. Recognition, they had an awards banquet, all the relevant leadership was there. That was nice, I certainly appreciated that. So just some nice quotations from the physicians themselves. We actually have rolled this out to trainees. We have been racking our brains for how to do this in the outpatient setting and to engage nurses in it, nurses and other clinicians. Right now, I think it's officially open to physicians, but I think they're trying to expand that and looking at how to expand that. It's just that the nurses, it becomes a little more challenging because they're not employed typically through the department. On the School of Medicine side, they're employed through the health system, so that the finances just change a little bit. So it's not as straightforward. And then I mentioned at the beginning, we are actually trying to combine these engagement incentive programs into one, which is still ongoing. I mentioned that clinician education around quality improvement scholarship is something I'm passionate about. I lead this program for Stanford faculty. We call it the Quest program. And we also have resources. We have our Stanford Center, Medicine Center for Improvement. We also host talks similar to what you guys are doing, which I think is great. I'm sometimes on the other side facilitating those talks. So, and there's resources on that website as well. You guys also have great resources. And then this one just came across my inbox. The Society for General Internal Medicine is launched this program to develop faculty scholarship skills. And so that's another option for folks. I will pause it. There's my email, and I will open for questions and read the chat. I haven't read it yet.
All right, wonderful. Thank you, Dr. Vilendrer. We have about 7 minutes for questions. And they're starting to come in. So Rubina asked, could you please share what the IRB oversight looks like at your institution for the QI related activities? Do you have a separate channel for such approvals? And to clarify, the second question is about patient engagement and incentives. So what about patient engagement in QI? And could you please share some examples of such incentives?
Okay, so the first question, IRB oversight. So every project goes through the IRB through a non-research determination. So in our health system, it's sort of a 2-page, more straightforward document where you describe your project. The key here is the primary goal is improvement of the healthcare system, which is true. Like I mentioned, there's a few projects here and there that don't get published, but that's sort of we're doing it. We wouldn't be doing it if we weren't interested in improving patient care at Stanford Medicine. And so that as a secondary goal, scholarship is possible. And so that usually gets approved pretty quickly if you read through the primary language. And if you want to email me, I can send you something. I put together a little blurb kind of like describing this. So that's nice. And it usually gets approved as non-research determination. This falls under the exemption of health systems needing to improve their activities. And then we usually treat everything as if it was research. So because we have this great team of trained researchers, we get consent from everybody. Everything is confidential or anonymous. All those good research practices that we would do. This is your second question on patient engagement and incentives. We try to involve patients in as many. Rubina, if you want to put your email in the chat, that'd be great. Then I can send you that. So we try to include the patient voice in as many projects as we can. Some projects are all about the patient voice. Anyway, we've done projects all about the patient voice. We don't usually incentivize patients to participate in quality improvement initiatives. There are usually enough patients that have a lot to say about their experience. They're happy to have a conversation. So we don't like pay them for that typically. And so, yeah, we're just, it is hard to get that voice. But we find that if we call enough patients and usually, so we'll go into the Epic records, maybe let's say we're talking to patients who have had a specific procedure, we'll pull a list of those, and then we'll just, call them if we're trying to get interviews or get their voice. And people are usually willing to talk to us without any funding.
All right, thank you. Debbie asks, can you talk a little bit more about dissemination? For example, when you have co-first authors, how is writing divvied up? How are you able to meet your summer deadlines, et cetera?
Yeah, so so it's bespoke. Every project is unique. So co-first author, we meet typically every week. So we're assigning different sections, and we have a great team approach where, if a project manager who has some qualitative research experience, who's maybe conducted the interviews, they're maybe at the master's level, they'll sometimes draft some of the tables, they'll draft the methods section. And so we really just work together. And I think there's been a few cases where because clinicians are busy, they got, engaged in something else, where our team, because we want to get that paper out the door, will kind of do more than our fair share. So that is, certainly a challenge. And so we're trying to get better about screening people who are really going to put the time in. But sometimes those are hard to avoid. How are you? Yeah, are you able to meet your summer deadlines? I think I chuckled when I said summer deadlines, because they don't always happen. But usually the idea is that summer, when more people are on vacation, that's kind of like a quieter writing time. And so we really just try to emphasize, we do, writing meetings, especially for some of the junior writers who haven't done it as much. Or like we'll get in a room and we're just writing together. I actually just put on Spotify and turn off my phone and lock the door, and I just try to write as much as I can. That's how I do it. But everybody has their own perspective.
All right, well, we have time for one more question, and Shanaz states, thank you for a wonderful presentation. Agreed. What was the biggest systems barrier related to these incentive-based QI initiatives?
This is a great question. It's hard to pick one. I think the most frustrating one was the lack of just easy access to data from Epic. And so there's actually a company out there called Atropos Health. I'll just type it into the chat. And they have been helping us get some just early data. And then we have our analyst who has full access to Clarity. But even getting some of that data, there's just so many things. As anybody who's worked with EHR data, there's so many considerations. How do you define the group? How do you define a comparison group? What does this data mean? But this startup out of Stanford, Atropos Health, they have access to our sort of like sandbox is what they call it, like not within the EHR, but one day delayed, it gets dumped into this thing where they can then pull data from it. And so they can actually turn that around really fast if we just have, simple questions as we're scoping a project around, how many patients have undergone this procedure, right? If it's a neurosurgery procedure and we're thinking, is this a high impact project for the institution? How many, if this only affects 15 patients a year, maybe we should pick a different project to give our resources towards. So that's been probably the most frustrating barrier. And then I think just another barrier is just, especially now that we're talking about combining these incentives into one program. Stanford is a place of a lot of leaders. There's this phrase that says like a 1,000 flowers blooming. And I've got my 1,000 tulips behind me blooming. People have kind of their domains, and it's a very slow process to get everybody on board agreeing to the same incentive plan. So the department chairs, you're changing the incentives on them. There's several meetings where between the health system and the department chairs where they're going to agree to that or not agree to that. And so I think for me, I like to see things done quickly, and scale things up, and just getting everybody on board is sometimes a slow process. And I'm sure U of M is probably no different. Probably most academic health systems are no different. So.
All right, well, thank you, Dr. Vilendrer, for taking the time to present at the CLHSS Impact Seminar, and thank you all for attending. Again, in closing, please join us on August 1st at noon Central Time, where we will be joined by Dr. Taj Mustafa. And please check out our inaugural upcoming Advances in Health System Sciences conference on September 18th and 19th. This concludes our presentation. See you next time.